Is your back pain that severe, that debilitating, that you consider surgery as your only solution? Today I'm here to interview the spinal consultants of the Brisbane Spine Clinic so that they can educate you about alternative treatments to spinal surgery. Today we're here to discuss the second opinion to spinal surgery as a treatment option for people who've been referred for surgery but they might be a bit anxious or there might be some fears around it. So can you just introduce yourselves, what you do, and talk about this second opinion to spinal surgery treatment that you offer?
Hello, I'm Caroline. I'm the spinal consultant of the Brisbane Spine Clinic and also specialize in women's health.
Hi, I'm Justin. I'm the director and the co-founder of the Brisbane Spine Clinic. I specialize in treatment of patients who's tried surgery and failed, or who's been referred for surgery but is looking for a second opinion to surgery.
Hi, my name's Leo. I'm the co-founder of the Brisbane Spine Clinic. I specialise in headache and sports injuries.
And so with this second opinion to spinal surgery, can you tell me about the types of patients that this would be suited to and, the process for them to come in and seek this treatment?
Yeah. So the treatment that we provide, obviously, it's really quite gentle. It's non-invasive, so it really is quite safe and suited for patients across all different sorts of age groups. The patients that come throughout or that sees us obviously have been referred, most of them have been referred or surgery has been mentioned to them. There's a small portion of patients that have tried surgery but it hasn't worked for them and we're able to get good results for them after a course of treatment for them here at the Brisbane Spine Clinic.
And there are also a lot of studies that are trending towards conservative management over surgical intervention these days. Surgeries do play a big part in a lot of the clients, but a lot of the researchers are saying that there is an ideal client for the surgeries, and most of the other clients, which statistically is about 90% of the clients, can be managed through conservative management.
And also with my female patients, I offer a lot of rehab exercises. A lot of them is actually to do with pelvic floor exercises, and they actually play a very important role in the recovery of the condition as well.
So you've talked about this conservative management. What is that? What does that involve?
So conservative management is basically opposite to surgical intervention. So there's no, it's a management where you don't need, it's a natural management where it could be a physiotherapy management, exercise, medications, also conservative management. So anything before surgery, we just call it a conservative management.
And the process of what we do, basically, because we strongly believe that our human body functions as one unit, so it doesn't really make sense to break up our different body parts and try to target and treat them individually. So that's why we adopt the approach we do. So sometimes when patients come in, actually for most patients that comes in seeking treatment for the stubborn chronic back pain or spinal pain, regardless of where the location of their symptom is, we'll run through a very thorough assessment from the head to toe, just trying to identify all the possible contributing dysfunctions which would cause their symptoms.
And with these patients who are presenting for a second opinion to spinal surgery, do you see common fears or frustrations within this patient group?
Yes, we do. Like when patients do get told by the doctor that they've got a vulnerable disc, the first thing that's going to come up with is fear. And then they end up with a lot of fearful patterns to move, and they feel like their disc is vulnerable, they can't move anymore. But the thing is, doctors nowadays, they give out a lot of pain medications, but it's only going to mask the problem. It's not going to actually get down to the bottom of that issue. So yeah, we do things different here.
Yeah, and I guess also to do with fear as well. I think so. A lot of patients' fear actually do stem from fear of uncertainty. Because when surgery has been put on the table, sometimes it is not the best option, but the only option from their perspective that's left. So before going into surgery, this is just common sense. If I was going to go for surgery, anyone's going to go for surgery, we need to have our questions answered. First of all, what does it involve? What are the risks? What's the success rate like? What's the recovery period? Am I going to be able to get back to what I used to do before? Am I going to fully recover 100%? So a lot of those questions really aren't answered before the patients were made to make up their mind. Yeah.
And usually those frustration and fear can result in the intensity of pain. There's also a lot of studies that lower back there's a lot of psychosocial factors that play a big role in the intensity of the lower back pain. And usually the fear and the frustration can also have a big impact on how patients' overall pain level is. And us as clinicians, it's our duty to actually help them to understand there are different options to other than surgical management. And it's most of the time, this is from my experience, do give patients a very big hope, and it actually helps in terms of their pain level as well.
And do you see any hesitations with getting, I guess, support for their back pain due to the nature of their work, or, that fear of having to take time off work, or, if they're not doing anything, is it going to, increase the level of pain so they can't work in the future? Like, do you see any of those frustrations? Or?
Yes, obviously patients who work in a labor job such as a tailor will be completely different to like a desk job person, because they definitely going to use their back a lot more often, and then they end up with a lot more frustration that I can't use my back, and then they started to actually question themselves, like what is actually going wrong with myself. But things that patients have to understand nowadays is if a condition is severe enough for them to develop, there must be something else that's going on behind it, so that we can actually, that's what we do here. We actually do a very thorough examination and really find out what's going wrong first, and then we treat them, other than giving them just generic exercises with and see you later. We don't do things here at all. Yeah.
And I guess, chronic back pain, it is not a simple issue. It is really a complicated issue. If it was a simple issue, we wouldn't have so many patients suffering with that with no results or no improvement at all. So just going back to Caroline's point about the patient that we see, we have to, as clinicians, we have to understand the connotations of their symptoms to how it actually affects their life. And sometimes, actually, for patients, just by realizing that and making them understand that there are other options rather than surgery, they, just inspiring that hope in patients, I think it's already a great start for the recovery process. And most of the patients that works with us do understand that treatment is a process. There's no overnight fixes. So it really is a journey, and what we're here to do is we're here to guide our patients through the journey to the recovery.
And usually when clients do come and see us, they've with chronic lower back patients, they would have had an MRI done, they would have had various different scans done, they would have visited GPs, and the first thing they would say is, I've got a disc bulge. And look, disc bulge is a diagnosis through an MRI, but it doesn't necessarily have to be the cause of the pain, and it usually isn't. And people end up going for an MRI when they do have low back pain, but MRI just shows that they do have a bulge, but it doesn't really show when they had that bulge. And usually by people with the age over the 40s, 50% of the people would have that disc bulge. And with these chronic low back pain, yes, disc bulge can have a bit of an impact on their pain intensity, but there are other factors that can also play, and we usually do find other muscles and joints that has a great play in their pain outcome.
And again, just going back to Leo's point, there's been many studies done across the world that's looked at patients' radiological findings. So they actually took patients' MRIs and look at the symptoms they have. And a lot of times it doesn't correlate. And to make a judgment of whether or not the patient has back pain or not just based on the films, a few studies looked at that. The success rate of, judging or guessing whether or not the patient has back pain is really, really low. So really, a lot of times we really have to take this with a pinch of salt. The more current trend of thought is that degeneration in disc bulge is actually a process of healthy aging. Unless we are seeing other signs and symptoms associated with that, we really can't make jump the gun and make that quick assumption as going, your back pain is from this. I think that's just not the right way of looking
And
at
then
it.
lastly, something I wanted to point out is from research, there are actually a lot of patients who do have this bulge, but there's just no symptoms. So people do really have to actually wait it out and really have to make an informed decision as to where they're actually going for. Yeah.
So if I've been referred for surgery,
Mm-hmm.
what would you recommend to me?
Well, the first thing I'll recommend to you is ask your surgeons all the questions that you have. Because as I keep saying, unless you are the ideal candidate, which we do recognize as a group of patients that will respond really, really well with surgery, unless you fit that specific profile for that specific procedure, it really does make sense for patients to consider other forms of treatment as well if you don't know the success rate of the surgery.
And usually even patients who's actually undergone a surgery or preparing for a surgery, pre-rehab and after rehab is very, very important. It's actually just as important as getting a surgery done. And I'm sure surgeons will definitely explain all that, but it is as a patient, it's their duty to actually ask them about all that as well. And just going back to what Justin said, just going through the basics, the common sense, they should cover all that and just check whether they're an ideal client for the surgery.
So essentially, if I've been referred for spinal surgery, you would advise to just ask the surgeon all the different options, how long, their success rate. If not, to just look at other alternative treatments and non-invasive treatments to help with that surgery.
Yes, that's correct.
Great. So there was a randomized clinical study in 2010 by JMPT that uncovered that people with herniated discs who received manual therapy treatment had the same results as those who received surgical intervention. What's your view on this?
So I've taken a look into this study, and basically for a study to make sense, the inclusion criteria for the people they choose has to represent the client that we see day in and day out. And for this study, that seems to be the case. So in this study, the patients were categorized randomly, but they included patients that we see, like for example, patients that had chronic back pain for more than, I think it was more than 2 to 3 months time, tried things like medication, tried massage, yoga, Pilates, and it just hasn't worked. So this study grouped them into surgery and non-surgical treatment, and the long-term results show that similar. So, but there are also other studies that prove on the other end of the scale. So there was a big study called the SPORT trial in the United States where they looked at 1,300 patients, one of the largest studies, and they followed those patients through to, I think, up to a 7 or 8 year mark. So what they found is surgery worked better for the patients. But then if you look at the inclusion criteria, they're very specific in the patients they picked. So they picked patients where, yes, there was a disc bulge, and a disc bulge which produced the expected symptoms in terms of the neurological pain and also neurological signs. So these patients obviously did a lot better than the non-surgical patients because they picked the right candidates.
So, based on a mix of your clinical experience as well as all the research, the outcomes of surgery versus, a manual therapy, so like 6, 7, 8 visits or whatever, what are the outcomes? Are there like comparable outcomes, measurable outcomes?
Yeah. So, if you look at the studies that's out there, obviously, first of all, for surgery to have a good outcome, you need to pick the right candidates. So in a lot of the long-term studies where they follow patients that's had surgery or unless this patient hasn't had surgery, you do see that surgery does yield a faster relief outcome, especially in that first year mark. So we call that kind of like a short-term outcome. But if you look at the long-term outcome, the significance, the difference actually starts to equalize out in the long term. So yes, it does offer faster relief if you're the right candidate. It does offer good outcomes in the sort of short to mid-term if we try to stretch it out a little bit, but in the long term, it really doesn't offer that much better outcome. So I guess as a patient, as anyone that's making a logical decision, you've got to weigh up the risk versus the benefit. So if you're going to get the same outcome in the long run, or minimal advantages in the long run, but having to go through all the risk, cost, recovery time, uncertainty of surgery, it really, it's a difficult decision to make. Okay. Yeah.
So at the Brisbane Spine Clinic, do you see people who have gone through surgery and they're still experiencing pain? Do people experience pain after surgery?
A lot of them do actually come back after surgery, and that was a lot of pain. It's very common for people to actually redevelop something else because obviously the operation was not actually getting down to the bottom of the cause of the problem. But luckily and interestingly, a lot of patients that we see here gets a lot better after proper treatment. So it's very important for actually any therapist to actually figure out why they had it in the first place. That's something that we really want to stretch out today.
And just going on Caroline's point, a lot of patients after they've had surgery, the innate belief is that their back is not as strong. So the innate belief is that their back is really fragile. So what that tends to happen is a lot of patients we see start to develop this protective strategy where they're so fearful of movement. So they hold themselves rigid and loses all the range of motion they should gain. And that kind of movement pattern actually drives further pain. So the patient ends up going into that pain cycle, which we are here to help them try to break. In the long run, we should be able to get back for our patients a lot of good flexibility, a lot of normal range of motion, and pain-free movement in the long run.
So usually after the surgery, what happens is usually when people come back after surgery, this is from my clinical experience, people do come back with more pain as before the surgery. And that is usually because they start to develop, let's say, other joints start to get a bulge or any other issues. And that's because you've done a surgery to one area and they're quite hesitant to move and put pressure into the area. They tend to develop other joints and other injuries as such. So conservative management and our treatment can complement along with the surgeries to help and benefit patients with greater success.
Right, so as a practice, do you believe that spinal surgery is unnecessary?
Well, spinal surgery definitely has their place in the management of our patients, but we keep stressing one point. You have to be the right candidate for the surgery. Otherwise, the risk and the benefit doesn't really weigh up.
And as Justin touched on it before, usually those ideal clients are the ones with neurological symptoms, and they do, from physical examination, we can definitely tell that if they would be the right candidate for it. And usually it falls within 10%. So about 90% of the patients who actually are suffering from chronic lower back pain, conservative management definitely can help. And look, surgery should be minimized, and nowadays surgeons are very good at explaining those, and they do try out all the other remedies before they actually start to consider about surgeries. So as I mentioned before, you should seek as many advices as possible before you actually go under surgery.
There has been a patient that I've managed. This is quite an interesting case. I hope this video is long enough for me to share it. So the patient initially presented with just a light numb patch on the side of the thigh that couldn't feel. They lost the touch sensation to it. So on the initial examination, she was okay. But then on the second visit, she started talking about the fact that she can't lift her foot up. For us, this is one of those signs that we talked about. We call this a foot drop sign in professional term, where the patient loses the motor function in one of the spinal nerves. That patient I referred for emergency MRI immediately, and they were able to catch a disc that's about to break off and compress on the spinal nerve. They were able to catch that soon and perform a good surgery. The patient ended up with a very good outcome and has been functioning fine and been healthy since.
Yeah, and I've also sent many of my clients for a further review and a second opinion to the surgeons, and they are usually what Justin has mentioned. They do get either weakness, foot drop is a common sign as well, and it all starts with a patch or a very located pins and needles or loss of sensation. And yes, if you do experience any symptoms like that, you should go seek medical assistance as soon as possible.